Welcome to Awakening with Ashley. I am so thrilled to have you here. We are talking all things women's health, hormone replacement therapy. We are going to dive into everything from endometriosis to birth control to symptoms of perimenopause to sex lives, and especially advocating and taking control of your health as we age and through every single stage of a woman's life with Dr. Sarah Duckeret. Thank you so much and welcome. All right. So Dr. Sarah, I would love for you to tell us how you started InnerBalance and what's unique about it, because it's a really unique product on the hormonal market. And this is obviously such a huge wave. The menopause, perimenopause space is exploding. So tell us how you started InnerBalance.
Definitely. We launched InnerBalance in February. Before that, I was a physician in a clinic for years. So I treated both men and women with hormone replacement therapy, but I'm also a longevity specialist. So I specialize in increasing health span or making people live healthier for longer. I started InnerBalance earlier than that when I delivered my my only child. He's 9 now. And I was in my mid-30s and never really recovered. So my hormones never came back up. And I was like, I'm not going to live like this. I deserve better. Like, I want to feel better. I'm just only 35, want to feel my best. And I'm a physician, so I have access to literally everything. And when you're that young and you try everything on the market, the patches, the pills, all of the options, and you realize that nothing is really that great, especially for, even younger generate populations, really they're meant for age 55 and above or 60 and above to stop hot flashes. Realizing that not only did we have no advancements over the last decades for women, and largely because we feared hormones, right? So you're familiar with the studies that came out decades ago that were wrong and, said that estrogen caused breast cancer. And so really because of those studies, there had been no advancements. And I realized also that I didn't learn anything in medical school. Nothing. 0 hours. I had no idea, didn't understand it. And so when I really dove into it, because I am specialized in the pathophysiology of disease, right? So I really wanted to know what that was. And when I started discovering it and learning that hormones govern, somebody said that hormones are the CEO of the body, right? They govern everything, literally every process in your body. You realize that you really can prevent and heal disease with them. They really are the core root cause of a lot of problems and health-related problems that we have. So I started InnerBalance because I needed it, really. So over time, I perfected it for me so that I could feel better. And then I realized that I wasn't alone. I was like, oh my gosh, this is really a thing. We treat men, in their 20s, they go, this is a normalized thing now. Men become low in testosterone, right? So we treat them. But for women, we microdose them. We're like, oh, no, you're normal. We gaslight them all the time. You're normal. You don't need hormones. You're having a period, so your hormones are normal, right? We've all heard of the story, this is what we're all going through. And so, and I realized we weren't alone. I wasn't alone, and that this is a thing that's happening younger and younger. And you realize when women get over the age of 30, their hormones drop by 80%, right? This is not a menopausal thing. This is not wait till your period stops when you're 55. Women are struggling for decades. Their hormones will drop by 80% over the age of 30. A lot of them will still get pregnant. We're still, have some fertility. But in general, women literally struggle for a very long time. So that's why I started InnerBalance, because I want to make it as easy as possible for women to feel great. And you don't have to wait. In fact, you shouldn't wait, right? There's no reason to. So that's the idea, that it's online, it's easy. The formulation is easy as possible. It takes 30 seconds a day. Try, do it. You'll invest in yourself. That's the whole idea.
And so it's a vaginal cream. And do your patients get tested first, or how, what's the sort of onboarding for a new patient and to get them into their proper diagnosis?
Well, we can talk more about labs, but labs right now in the state that they're in are not great. In fact, they're a disaster, and so I will always believe a woman over a lab test, right? If she's having symptoms, she knows better than anybody. Hey, I don't feel like I used to, or even a year ago. And even if she feels okay some of the times, that doesn't mean she should feel great all the time. And so really just relying on her. I mean, she's an adult. She knows that she needs it. Getting started, generally, if they're over the age of 30, they're not making hardly any hormones, or at least the hormones that they need to support themselves. So I just get them started right away. And they know, like if they don't feel well, they can always stop it and they just go back to what they were before, right? And in general, everybody feels better. And so, and my philosophy is that we test after 6 months so that you can see that your levels are optimal, so we do have some idea of what some optimal ranges are.
Mm-hmm. So let's talk about the difference between normal ranges of hormones and functional medicine or optimal ranges, because I think a lot of women out there are going to their physicians. And as you said, we know so many physicians are not educated in hormonal health or not well educated, I should say. And women are generally getting subpar care. The standard of care, particularly for hormonal health, I think is just, it's not optimal. And I've also heard, well, I'll ask you that question in a second, but let's just talk about functional lab windows or optimal lab windows versus normal ranges. So what should people look for? And maybe we just limit it to the three, primary hormones of estrogen, progesterone, and testosterone.
Yes, definitely. So labs report a reference range based on what the manufacturer of the instrument tells them to. This is what labs do. Okay.
Wait, say that again, because that's really important.
Yes. So labs do not, as the way that we establish these reference intervals is not very impressive, right? Mm-hmm. So manufacturers will do just the bare minimum by federal law, and then they report, the labs they never question it, right? So when you look at estrogen, for example, estradiol, which is the main feminizing hormone for women, but that hormone, it has an upper limit of 400 picograms per milliliter. Okay, so that range was based on 49 women only. 49 women and 100 men. So the men were included in our study, which is mind-boggling. It's bonkers. And also, so doctors will only really, if it gets above 400, they're like, this is too high. When you look at studies, more modern studies done by mass spec, which is a really fancy instrument, it's a really more, those are also based on older, really outdated instruments, right? So we have better stuff now in the laboratory. So mass spec, we see women that are ovulating around age 25, between 20 and 30. We can test them every day of the month, and we know that their peak estrogen levels when they ovulate can get up to 1,800. Mm-hmm. So this is really what's optimal. This is what we should be aiming for when we're replacing a 40 or a 45-year-old. Hey, you want to feel like you're 25? Then this is the range that we should be trying to optimize her to, which can be all the way up to 1,800 and sometimes more, because that, again, those studies are based on maybe 200 or 300 or only 400 women. That doesn't mean that you shouldn't be at 3,000. Or, I'm just, throwing out numbers, but you don't know what your baseline is. When we look at other hormones, testosterone has the most studies on it because of males. Yeah, mm-hmm. surprise. So testosterone has thousands of studies. But progesterone is actually arguably the most abundant hormone in women. And it's because there's a lot of confusion about this because the way that labs report them. So all the three hormones are in different units. So estrogen in picograms per milliliter, testosterone's in another one, nanograms per deciliter, and then progesterone is in its own unit as well. And they put it in a different unit because it's magnitudes larger than the other ones. Mm. So then when progesterone, when it says number 2, that's actually 2,000 picograms per milliliter. So it's 60 times higher than testosterone and 16 times higher than estrogen. 60 times higher than testosterone, but yet a lot of practitioners focus on testosterone, giving that to women, and it ends up making women irritable. They lose their hair, they gain weight, they get bloated, they get a lot of side effects. So yes, testosterone is important, but it is not the main hormone for women. Mm-hmm. And so there's only 5 studies in the entire world, and none of them have been published in the US, right?
5 studies on progesterone.
On what is an optimal reference range? Mm-hmm. What are women in their between 20 and 30? What is the optimal range that we should be aiming for hormone replacement therapy? Right? So how do we, we know how we establish this for men, and we can get into how we would establish this for women, and that's what we're doing in InnerBalance as well. What do we establish as an optimal reference range for progesterone?
Yeah. And it's so maddening. And this is why I'm so passionate about the new body work that I've been growing into, which is menopausal health, perimenopausal, menopausal health for midlife women. And I want to talk a little bit about, because I hear so many women that go to their doctors and either, as you said, there's a lot of gaslighting, or there's sort of this assumption that let's just get you on estrogen. So let's talk about why progesterone is so important, if not as or more important than estrogen. So what are some of the symptoms that women will recognize in lower declining progesterone?
So the symptoms that women notice the most, I would say, are mental health. Like, it's very universal. So like anxiety, depression, irritability, and insomnia. And this is huge because when you talk to women, it's their priority. It impacts their work, their relationships, with their kids and their spouses. I mean, they want to feel great, and that's mental health, right? And so progesterone is a neurosteroid, and it also breaks down into neurosteroids. So allopregnanolone is our main one. And there's like receptors like all over for this hormone. And so when progesterone modulates the GABA receptors, which is also what it's like literally women's benzodiazepine, right? It is like how we can feel calm and centered and relaxed and able to tolerate small children, let's be honest, like, and be pregnant and like that whole state of pregnancy. Progesterone gets up to 300,000 picograms per milliliter. You see women, they're like, chill. Like, how can you be chill? Like, you're like pregnant and you have this is nature's way of keeping women. We have a very complex neuroendocrine system. We're practically a different species than men. Yeah. Right. So we need progesterone to maintain this calmness. So that's one. Another one is progesterone counterbalances estrogen all over the body. So like, they perfectly balance one another. Mm-hmm. So if estrogen causes dilation of the blood vessels, progesterone constricts them, right? So like even to maintain like blood pressure, you need both of them. To maintain the lining of the uterus, estrogen stimulates it, progesterone stops that growth, right? So every single process, women are more complex than men. We don't need just one hormone, we need both, right? They totally balance each other. Sex drive, you'll need both. Skin, they both like help with that healthy glow, thickness of the skin, collagen and elastin formation of hyaluronic acid, hair growth, right? Estrogen causes the hair to grow, progesterone stops it. So that's why when we look at, if you give somebody just estrogen, there's no guidelines for how much. It's based on tolerability. It's like, oh, just give her as much as she can tolerate, but she's not going to be able to tolerate very much because she's not being balanced with progesterone. So unless you give her first hormone, then you can give her estrogen, which is kind of the feminizing hormone that we think of.
Right. So so I think of like estrogen and progesterone, sort of the yin and yang, or, that beautiful tango, that dance of the, we in a normal menstrual cycle, they're ebbing and flowing, synchronized with each other. And for myself, the shift in mental health was my biggest symptom of perimenopause. And it was absolutely debilitating. So my experience with depression, which probably could have been a clinical diagnosis of depression, extreme anxiety that I had never experienced before, depression or anxiety, I never really experienced before, loss of just tolerance, loss of agency, loss of confidence. Maybe that's a little more due to the testosterone, the declining testosterone, but I just felt like the rug had been pulled out from under me and I couldn't manage my normal life, much less any additional stressors. It was almost unbearable until I got on hormones, on hormone replacement therapy. So I just want to emphasize that for anyone listening. And again, to your point in the beginning, this can start in our 30s, as early as 30, 35. And I think that's really important for those of you listening who are younger, to really think about, watching your symptoms, monitoring your symptoms, tracking your symptoms from much earlier on, right? So that we have maybe a normal baseline, or at least some sort of baseline to assess as we start to age. So you said for progesterone, the depression, anxiety, I also want to highlight the GABA receptor. So the impact of hormones on the neurotransmitters, and then the neurotransmitters on our mood and our mental health. Because as a psychotherapist, much like you as a physician, I was never taught one thing about the relationship between hormones, neurotransmitters, and mental health. And even as a psychotherapist for 20 years, a wellness professional for 30 years. It took me probably 2 to 3 years to self-diagnose and realize that I was having severe mental health issues, and it was probably related to perimenopause. And so I want to underscore that for people, because I think many people think about perimenopause and just focus on hot flashes, night sweats, maybe I'm gaining weight, or I don't have my period, my fertility is dropping, not realizing the correlation. So progesterone, GABA is the calming neurotransmitter. And when you start seeing shifts in your mood that are abnormal, that you've never experienced before, getting your hormones checked is one of the primary first interventions, for sure.
Definitely. And I'll also mention, it can be subtle too, but it's really not. Like, women know that they can't tolerate their spouse anymore, their kids anymore. I mean, it can be just that simple, the irritability, or that kind of, I'm slamming cupboards. Like, I'll have patients say, like, I'm in the kitchen slamming cupboards, and also not another mental health concern is also lack of focus. So this like mental clarity that comes up, and this can be often dismissed as like adult ADHD, which can be, right? So it could be like a person that had ADHD as a child and got missed, and girls get missed all the time because they're not hyperactive. They're not disruptive in class. They still are very bright, and they usually make it just fine without any kind of diagnosis of ADHD. They can make it all through their 20s, and then they get older, and then perimenopause hits and they get worse. But it could also be perimenopause just causing them to have lack of focus and mental clarity, and that's what they call brain fog. And I think that this is important because dopamine, we need estrogen to make dopamine, right? And estrogen raises that. So, and we need dopamine to focus, and we need dopamine to like feel like we can do that, and norepinephrine as well. And like when they work together, you can focus, and we need estrogen to do that. And then testosterone to some degree, but progesterone converts to testosterone. So if we have plenty of progesterone around, then you will be able to have these other things that testosterone offers from a cognitive standpoint.
So many aha moments. And one of them for me is the ADHD. I want to unpack that a little bit, because for myself, I've been questioning I just turned 50. So I've been questioning, do I have ADHD? Like in the last, I would say 2 years, I found it more difficult to focus and separate from brain fog, like the brain fog and sort of slow cognition, which has gotten better being on hormones. But the difficulty in focus I've never experienced before. So talk a little bit more about a late stage diagnosis. I guess I should say a diagnosis later in life for ADHD, and what symptoms women can look out for, or even how to get diagnosed for ADHD.
Definitely. So this is fascinating, and I have like a personal interest because my son has it. So I definitely, but really ADHD. So, for a 50-year-old that gets diagnosed, say, or somebody even in their 40s that becomes this lack of mental clarity and focus and drive and motivation and just brain fog all over, I would still say that it's try to optimize the hormones first. Yeah. So if you're still feeling it on hormone replacement therapy, you're not optimized on hormone replacement therapy is what I would say, right? Like your estrogen and your progesterone are not what they need to be in order for you to feel like you have that ability to focus. Generally, people with ADHD will have anxiety their entire life. So like childhood ADHD turns into adult anxiety. So like somebody in their 20s, like they don't know any different. Like they will literally have anxiety their entire life. That's just their baseline. They wake up in the morning with that impending sense of doom. Like if I don't stop moving, like I will fall out of the sky kind of feeling. Like I don't know if you've had people say that to you, in your sessions and like, working with people, but I find that like they get really worse earlier, like in their 20s and 30s. So like, I don't, I think I would look at optimizing you first to make sure that you are totally optimized. But even then, natural ways to raise, like, so there is a genetic component to ADHD, so these people tend to metabolize dopamine really quickly. So even if you're making it, and you're metabolizing it really fast. So there are ways to raise your dopamine. And so even if I don't really think that it is at value to get a diagnosis. Like in my opinion, I'm kind of like, okay, well, let's say you have it or let's say you don't, but how do you fix it? Like, what's the solution? And in general, people, when they can't focus, feel better when you raise dopamine. So how do you naturally do that? Hormone replacement therapy is number one. And then there's some natural supplements. We know that sunshine and hugs, things like sex and all raise dopamine. I mean, hugs are known to do that. Sunshine, exercise. People exercise, so there's a lot of things, but it is kind of a daily battle, right? But if you're on, you can raise that dopamine and feel much better. High protein diets can do it. We need protein to make dopamine.
And how much protein do you recommend a day? I know there's a lot of talk about that.
There's a lot of talk. And I just find that working with women who don't feel well, I'm like, look, just keep doing better and better. It doesn't need to be a full-time job to count macros. And I know that none of us. So I'm just aim for over 100 grams a day, which is kind of late. But it's actually, if you can make it over 100 grams, you're doing really great, which is hard to do. Right. If you've ever tried to eat that much.
Yeah.
So in general, but I know there's a lot of theories on if you weigh this many pounds, you can eat this many grams of protein. But I find that just try to eat over 100 grams and then you can really notice a difference. And if they notice a difference in their mental clarity and focus, then it's helping them and then they can continue to do that.
Yeah. Do you have any hacks for including more protein in your diet?
Definitely. So for ADHD women, so I also recommend L-tyrosine, which is a supplement that's just a straight amino acid that converts right to dopamine. And so typically this will help with a natural way to help you focus throughout the day. And then a really good way for ADHD women is, or just this, even if you don't have ADHD, look, you're struggling, you're having to perform all day long, and in the afternoon you still have to focus to finish your job. So collagen, because it's so easy to digest, and it's basically eating straight amino acids. You're eating them in their pure form that you can easily make into dopamine and neurotransmitters. Other forms of protein can be hard to digest and they cause bloating. So I've found that women will do plant-based proteins and they get bloated. And I just they don't know, nobody likes that. And you can get into what's easily more digestible, but I find that everybody tolerates collagen. They just feel like they have more energy and mental clarity with it. So that's why I just recommend that one and it's easy, right? You can add it to stuff. Everybody's on the go. Nobody's going to eat steak and eggs for breakfast. I'm not going to be I'm not going to eat steak and eggs for breakfast. You can add it to your tea and your coffee and you can add collagen to everything.
Yeah. Bone broth. Bone
broth is great too. It's really good. So anything that's a really easy thing to digest. Yeah.
Yeah. So you mentioned sex. So let's talk about sex. So what are your suggestions for women? And again, I like being transparent on this podcast. It's one of my intentions with being on this podcast. And drop in sex drive and painful sex were two of painful sex first was one of my first symptoms of perimenopause. And then later I would say a real drop in my sex drive, my libido. And it creates a huge strain on your relationship. And so even as a therapist, that's one of the things I'm most passionate about is really serving couples and giving people, different scripts and ideas of how to manage that change for both men and women, because a lot of men experience it too when their testosterone starts to drop.
No, I love it. And I love that you're doing that. And I think that's an important part of it, but I think just giving her what she needs to the root cause of that vaginal dryness and lack of sex drive is estrogen and progesterone. And we talk a lot about testosterone, but when you deep dive into sex drive for women is really common. Let's unpack that, but let's talk about vaginal dryness first. But vaginal dryness, the root cause is low estrogen, but progesterone also plays a role in that. So you'll see vaginal remodeling, increase in collagen, elastin, hyaluronic acid with both of the hormones. So you'll get a better effect if she's on both, right? The right formulations as well. And it has to be enough. A lot of these low dose vaginal estrogen creams on the market, let's be honest, no. And then hyaluronic acid supply, a lot of them are Band-Aid fixes. There's so much being pushed to women right now. And it's stuff that's a Band-Aid fix, like hyaluronic acid suppositories. Anybody's going to put that in and have sex? I don't know. No, you just treat the root cause. It's like erectile So here's the thing about sex too, is that we have a lot of shame around it. So for men, we've normalized this. Erectile dysfunction. Hey, a man goes to a doctor and he's like, I have low libido and low sex drive. And the doctor's like, you need some testosterone or Viagra. You have a health problem. This is a concern. We need to treat you. Right away, they'll treat him. A woman goes to a doctor and says, I have vaginal dryness and low sex drive. And the doctor will say, you should read a sexy novel and date your husband.
Yeah. Or it's just aging. This is just aging.
Or this is just it becomes a relationship concern. Whereas when a man has a problem, it's a health concern, and women are treated like they need to treat their relationship. And this is completely inappropriate, right? Yeah. Like physicians need to be like, this is a health problem. Like if she's having this issue that's showing that her hormones are really low, we don't need to wait for her period to stop. Or, this is a lot of that's going on. But
it's the misogyny. It's the misogyny of the medical system. And I think it's really important to focus on the words that we're using and call things what they are.
And I completely agree with you. This
is also, I want to really point out with female physicians, not just male physicians. I've been in a conversation with my gynecologist, who's a woman that I've been going to for over 2 decades, and her whole team and her whole front desk staff are all women. But I'm having to advocate for myself with them because the conditioning and the education is so, inculcated. It's such a culture. It's such a, they don't even realize what they don't realize, right? So I just want to highlight the need for women to advocate for themselves and for us to support each other in that and get information like this so that we can take it to our physicians and also call them out on this stuff. If we want it to change, we have to be the agent of change.
There's still a lot of misogyny in medicine. If any woman has made it as far as she has, it becomes ingrained in her, even the older the woman is, the worse it is, right? So the younger generations are a little bit better, but it's still very, very true, and I think also culturally, so we have normalized this erectile dysfunction for men, but vaginal dryness is just as common and it's just as big of a problem. Yeah. And it's borderline criminal to give men a husband a bunch of Viagra and testosterone and not treat the wife. Yeah. Right. And so you're not even addressing it. You're not even addressing it, and she's left with this another problem. Right. And this is very, very painful for her. So anyway, we also,
and not to mention UTIs, because vaginal dryness then can translate into future or more common UTIs, which is a huge health risk.
Pelvic health for women is really important. And I say a wet vagina is a healthy vagina.
Yes.
Because really what we're talking about is this is how the vagina cleans itself. Mm-hmm. This is how we prevent yeast infections. It has to maintain a proper pH to do that. Not just yeast infections, bacterial vaginosis. If you have bacterial vaginosis, it's because your pH is off, right? Is your estrogen levels. Lactobacillus acidophilus, which is the primary organism in the vagina. We don't want a diverse microbiome there. We want it everywhere else, but in the vagina, we just want 1 or 2 strains. And it's this primary one that makes it really acidic. It needs estrogen to make its food. If you just give a woman testosterone cream for her libido and you just give her vaginal testosterone cream, it will completely disrupt her vaginal microbiome. Right? She needs estrogen to do to maintain that, to prevent infection. Okay, so this is health concern. Infection, urinary tract infections. I see women that it hurts so much to urinate, right? It's so the tissue gets so thin and fragile and atrophied. Can you imagine if a man that happened to a man? That absolutely would not be tolerated. So it's women, pelvic health, and also urinary incontinence. Mm-hmm. When women become urinary incontinent, it's their world becomes smaller, right? Because they can't. So this is really important from a health standpoint, pelvic health, vaginal health. And it's never about sex at first, right? But then it's as the sex gets better, everybody's this is great, right? Because then sex starts to feel better and sensitivity increases and ability to orgasm, all that those get better eventually. But at first it's about the health stuff, right? Look, you've got to have a...
Yeah, I call it the menopause hierarchy of needs. And, the physical health is the foundation of that. Hormonal health is the foundation of that. And if we don't have that, it's really hard to solve any of the other problems because our whole system is really destabilized, starting with the body. But of course, as a psychotherapist, I just want to connect the dots between the physical health and the implications downstream of our own psychology, of our own mental health, and certainly of the relationship health. And when the relationship health starts to go, that is a huge pain point. We know that people in relationships live longer. There's such a high rate of divorce at midlife and with menopause. And I can't underscore this enough. And this is, I think this is one of the errors of the Descartesian split, the mind body split and the mechanistic paradigm that we look at medicine with, meaning we're separating everything out into its individual parts and not looking at the whole system being not just the whole body, but the body, mind, spirit, and the downstream implications of that, again, across our lifetime, but certainly across all the different realms of our life.
No, I completely agree with you. And I think it's a great way to put it. And I also agree with this, like the relationship starts to break down and, we have this divorce rate and it really impacts. And then sometimes that's when women come into the office is when it hurts to have sex. My husband wants to have sex all the time and now it's hurting my relationship. And so I also think that we should tell women at an earlier age that they need to prioritize their own sexual well-being because we as a society prioritize men's pleasure first, right? Yes. So this is so if we started young, and I think it's how we talk to our daughters about it.
Hopefully it's changing in the culture.
I think that, but I'll put women on our treatment and they don't talk about their vaginal dryness, right? They're not talking about it, but it's but it's okay. They don't, they've got plenty of other things that we're treating. But then they'll come back and they'll be like, wow, I didn't realize it was so Sahara Desert down there, because they're not prioritizing that. And they really should. That is something that as soon as they see that happening, that they need to not just use lube or use Band-Aid fixes.
Yes. I mean, and I think it speaks to the underlying, I've heard, called the orgasm gap between men and women, but it also speaks to not just the biology of vaginal dryness, but the effect on desire. And for me, I'm always connecting it to the psychology, but the shift in identity, right? And so I know for myself, I always identify, my sexual pleasure, well-being, identity was such a huge part of who I was in the world. And so when that shifted and it really went into decline, I was feeling, I think, more depressed because here's something that's an outlet for your creativity, for stress relief, for consciousness, exploring who you are in all of these nonverbal and really beautiful ways. And then when that's taken away from you, you're questioning, who am I? And the actual, some actual interventions. Sex is a great healer. It's a great stress relief. And so when you don't have that, again, it's adding and compounding
to depression, anxiety,
anxiety, sense of loss, sense of grief. It's an important
part of life. We should, you definitely should have the best sex of your life after the age of 40 and 50 and beyond. There's no reason you shouldn't.
What do you recommend for women how to prioritize their sexual pleasure? I
think that the more they know about it too, for example, when you talked about vaginal dryness being linked to that desire, I think that if women understood where that came from, so we know all, again, I don't want to talk about men, but it's we know more about them, unfortunately, but an erection, we know where that comes from, right? It's like a blood flow. It's just blood flow. Okay. So everybody knows that. But when I ask women, nobody knows what causes vaginal wetness or, their dryness. And it's blood flow too.
Yeah.
Right. It's blood flow to the pelvic region. And that blood actually seeps through the vaginal wall. And it's just filtered protein and water. And that's what causes that. So the more blood flow you have, but you can look at it as equivalent to an erection. Mm-hmm. So women should have multiple episodes a day. And you look at the teenagers, the girls, I had a friend who has a daughter, she's 13. She's I feel like I'm peeing my pants. And I'm yes, this is normal. So it starts when our daughters, how we talk to them about it.
Yeah.
This is normal.
Yeah.
And normalizing this, that this is a part of what your body's doing and it's healthy will help with that, how women can start to change the way they think about that vaginal dryness thing and how it's connected and connecting that because people don't, right? Yeah. They're not, women especially are not making that connection like you're talking about.
Well, I really hope that, I'm a Gen Xer, and I think in our generation, we've done a lot of work for shattering shame around sexuality. And I really hope, and I see that younger generations, Gen Y, Gen Z, I don't even know what you call the next generation, have done, much more work around deconditioning and destigmatizing sex, particularly for women, and the shame around it. And that's a huge piece of it, so that we're even talking. I think that's, it's part of what's gotten us here is women have never been talking about their sexual health, about their sex lives, about their vaginas, about menopause, about, these are things that have always been held in the shadows. And so if you were lucky, maybe you had a mom or a cool aunt that was talking to you about this stuff, but I didn't. I didn't really have that.
No, I didn't, and neither did any of my friends. Like,
right.
At least my general,
yeah. So there's just a lot of destigmatizing that's still going on. And I'm so happy to see our generation really taking on this journey of menopause. But again, bringing it to a younger generation and really educating people in their 30s, even 20s, about how to prepare and optimize for this journey.
And, it's important too, because we're seeing this drop in hormones younger and younger.
Yeah.
I mean, could be environmental, but I see people in their 20s that are suffering from PCOS, endometriosis, anxiety, depression, all the symptoms of low hormones. So it's happening younger, right?
And let's talk about endometriosis, because that's a huge topic. It's something I'm really passionate about. I have someone very close to me that, suffered and was really misdiagnosed, not diagnosed. And it created so many medical, issues and even emergency surgery. And so what causes endometriosis? What is even endometriosis for the person listening?
Yeah, I think it's important because it's really common.
It's really common.
And people just think it's maybe, I don't know what people think, but could be like a painful period, or
right.
Because we know that could be, was it a tolerance level? And so it's not just a painful period, right? So we know that the uterine lining is growing outside of the uterus. And so when it happens, it's not supposed to be outside the uterus. So when it happens to grow outside of the uterus, it does cause an immune response. So it causes the uterus to become inflamed. So that's one problem. But the real problem is that the immune system recognizes that the uterine tissue is not supposed to be there.
Like foreign tissue.
It's foreign tissue. So that it mounts an immune response, antibodies to it, as well as like cytokines. And so you get a whole body systemic inflammatory response, which is that, and it hasn't been classified as a true autoimmune disease, but when you have chronic inflammation, a chaotic immune system, and autoantibodies, you have antibodies to that endometrial tissue. That's like all of the components of a recipe, for an autoimmune disease. And then you get a lot of pain because these can trap nerves, right? So the tissue can like trap a nerve, it can trap blood, and then the blood causes even more inflammation. You can form like adhesions, which are basically these like bands of scar tissue. And so the adhesions will cause the uterus to stick to the fallopian tubes, to the ovaries, to the rectum, to the bladder, right? Like everything that's like here can like stick together. And so when they stick together like that, and then when a woman who has it moves, for example, like during intercourse or a bowel movement, even just going to the bathroom, she has extreme pain. So this is pain outside of a period. So like she's not just doesn't have to have a period to have pain. She can have like sex and have pain, but because of these adhesions and things that aren't supposed to be there. And so when you look at, what's causing that? Well, what stops the growth of endometrial lining? Progesterone. Right. And progesterone's arguably the main, most abundant hormone in women. And when it goes down, then this endometrial tissue can proliferate because it's not being stopped. And we also know that progesterone is the main modulator of the immune system. So when women get pregnant and their progesterone levels get really high, autoimmune disease goes away. Like celiac goes away, lupus goes away. Like we have studies to show that it goes away.
I didn't know that. I haven't heard that.
So it's like we know progesterone binds directly to B cells and T cells, organizes the immune system, regulates it. That's why women can have babies and not destroy their own baby, right? It's why it keeps the immune system from destroying the baby. It's like the beautiful thing that women can do that makes us like so like, women.
Miracle.
And that's why progesterone is like so important for women. It like really is core to even her immune system functioning. So her neuroendocrine system, her immune system. And so when she doesn't have any around, and then endometrial tissue is like all over the body because the progesterone's not stopping it. So progesterone is the solution, but the conventional medicine, it's like, well, surgery is the answer, which is really invasive. And then or birth control, my favorite. So like they'll say that.
Yeah, this is a big topic I want to talk about because I have friends now who are 50 and they're like, I'm just going to stay on birth control. But I think I should just stay on it because it's managed all my symptoms. And I'm afraid to go off of it because I'm afraid of the perimenopause symptoms that are going to come if I go off of my birth control. It's like, that is so upside down, but let's talk about it. Yeah.
It's like birth control in general then. Because like birth control, I mean, when they throw birth control at everything, and you can argue physicians make a living, they get paid, and they don't have a lot of time, but they do get paid to prescribe birth control. And they don't have any training. We already went over that. So, they don't have to know everything. But anyway, the birth control stops the production of your own hormones. So it makes them go to zero. And that's what they think the treatment is for like PCOS and endometriosis and all these problems in women. Well, you have a painful period. Let's just stop the period. Let's just stop all the hormones, make estrogen, everything go to zero. So when you have, and it's even worse when they're using it as a hormone replacement therapy because it's not, it's not hormones. It's not like what's mimicking your natural hormone in your body. Birth control has progestin in it, which is not progesterone. It is a fake thing that pharmaceutical companies have made so they can patent. I mean, progestin. And so everybody just assumes it's progesterone. But when it binds to that progesterone receptor, it doesn't do the same thing. It has like a stronger signal or a weaker signal. And in the studies that are concerning, that is what potentially increases risk for stroke and breast cancer, is that progestin. And, estrogen always took the blame for that one, as we know.
You're saying in birth control, progestin is not responding in the same way that progesterone does on the progesterone receptors.
Right.
And that
could
is
be
what
even causing
and that
harm.
could be linked to the increase in cancer risk.
Yeah. And the risk is small. Like,
Right.
let's be honest, like it's really, really very small. But if there is a risk, it's from that one and not our own natural hormones. And there is some evidence, again, this risk is so small, I don't want to mention it, but it's like the stroke risk, but it's like your risk of getting hit by lightning, maybe double that. It's really, really small, so, but it's there. And a woman over the age of 35, that increases. So birth control is not indicated in a woman over 35.
Yeah.
Actually.
Over 35. Yeah.
Right. And it's even FDA.
And I'm not familiar with the long-term effect of birth control if you're taking, and I guess you're saying it's stopping all the sort of hormone generation. What happens when you stop birth control? Does your body come back online, generating the same level of hormones, not as much? How's that been studied?
I think, they'll say there hasn't been studied that well, but we put women in their 20s on birth control all the time and they do get pregnant, but there are also a lot of women that don't recover, or they'll say it took me a long time to recover, or feel like they recovered. A woman over the age of 30 and 35 is not going to, because she's already at the age where she's not making very much. I think what's important is that women are just not benefiting from it. Right. So like you have a 40, 50, 60, like you have a 50-year-old woman who's on birth control. She's not getting the full benefits that she could from a bioidentical hormone replacement therapy. And I think that's the issue, is that we know how protective they are, and they're going to protect against all these diseases of aging: Alzheimer's, osteoporosis, dementia,
cardiovascular disease,
heart disease, which is huge. And then breast cancer. We now think it protects against breast cancer.
Right.
So you're not giving her that benefit. And that's the problem. Like you're kind of masking these symptoms for her, but you're not offering her what she could potentially like benefit from.
Yeah. One thing I want to touch on, which I've heard from, I come from the yoga world, a more sort of holistic, integrative approach to medicine. And I'm hearing a lot of my friends and clients who are more oriented in that way saying things like, I don't want to go, I just want to do menopause naturally. I don't want to go on hormones because it's not natural. I feel okay. I'm just going to, I'm just going to manage this myself and I don't need the hormones. And I want to underscore this and say that obviously going on hormone replacement therapy is a very individual, like any medical decision. It's totally individual. When I hear that, and I've heard some of my very dear friends say that, and the research that I've done, and by no means am I an expert, but understanding how neuroprotective estrogen is, all of our hormones are, the long-term benefits of hormone replacement therapy, not just to manage your symptoms, but as a preventative measure for things like brain health, cardiovascular health, bone health. I just feel like, are you really having an educated conversation with your physician? And is your physician even educated on this? Let's just make sure everyone has all the chips on the table so they can make that decision.
Yeah.
Because I feel like it's still so skewed.
You're 100% correct. And like, would they make that decision if they had all the information in front of them? No. And it just because it's natural doesn't mean it's better. And there's no badge of honor for you doing that.
Yeah.
You know, and you can still be healthy with the yoga, and like you still have to do all those things.
Yeah.
You know, the
lifestyle
diet.
medicine.
Oh, absolutely. So it's not like that you're ever going to escape that. But it's just so obvious what the benefits are that you can, you know, don't you want to be doing yoga when you're 100?
Yeah.
I mean, I do, right?
Yeah.
So
I mean, I have friends that say that, you know, they've been going through severe debilitating hot flashes for 6, 7, 10
decades.
Years.
It never stops.
And they're not considering hormone replacement therapy. To me, that's really, you know, prohibitive in your life. And that's having a direct impact on the quality of your life.
So a hot flash is the very last thing to happen.
Yeah.
The period stopping is the very last thing to happen. But if you're having hot flashes, your estrogen's below 100. And it's because the hypothalamus has receptors literally to maintain your body temperature. Mm-hmm. And if you cannot maintain your body temperature, that's a really hard way to live. And it doesn't stop, right? So you go a decade with this, and it's not just it's not sweating. It's like a sense of impending doom. It's like, it feels awful. Right? When people go through it, this is not just sweating. I think we need to like emphasize what they're feeling.
Yeah. And also the research that's coming out now on the effect of those vasomotor symptoms on capillary health, on cardiovascular
like mini strokes
health.
Or whatever. Yeah. Oh no, it's, you shouldn't even wait until you have hot flashes. You should, as soon as you start with even the mental health can be that first sign of anxiety and depression, irritability, what we talked about the first of the podcast. Mm-hmm. Women should get on it then, because they shouldn't wait until they're in this situation of having these hot flashes.
Right. And the longer women go without hormone replacement therapy, the less effective it is later. Is that right?
I think that you're just going that long without you. When you go without it, your body deteriorates.
Right. You're not getting the protective measures.
Yeah.
Of the
So it's just
buffer.
You're kind of like
and functioning.
Hormones work best as a preventative measure. So if you can prevent, as opposed to like trying to go back, like heart disease prevention starts at age 20, like you got to prevent it. And you're at 50, 55 and you're trying to, it's much harder because you've already let it sit for a long time.
Yeah.
So that's
the damage has been done. Yeah. So let's end this on a positive note. And I do think it's really important to reframe this journey of midlife and perimenopause, menopause, instead of around the emphasis on everything we're losing, losing hair growth or hormones or sex drive, and focus on the power of midlife and the power of one of the things that I've seen is really taking this agency and taking this advocacy and, propelling us forward, I think, into a new level of autonomy and sovereignty and confidence as women. I'd love to hear just sort of your thoughts on that journey psychologically of women in midlife, what you're seeing with your clients, what you're seeing as the future of women's health in the most, what we're really aiming for and thriving.
Yeah. And I think women are starting to take complete control in charge, and they love it. And they're like, I'm going to feel great my entire life and put off disease and live as healthy as possible for as long as possible. And they're starting to realize that they need to do that themselves. And it's so empowering. And the more that they learn about it and they do it, and they are doing it, like we're seeing it. Mm-hmm. And so hormones are that answer, right? Like that power that made the body will heal the body. And to know that you can have control of your own health and future, and that if you have something going, it's not lost because you actually have control over it. You just need to recognize that symptoms and then stop it, because now we have the answer, we're getting there. But yeah, women are starting to see this like shift where they're really like not going to stand for it anymore.
Yeah.
and they deserve it, and they shouldn't. And it's like the time of their life where they have like their kids, they want to be as, I'm like, I don't want you to slow down. I want to give you the energy, like all the tools that you need and all the support that you need from a biology, medical standpoint, or whatever I can do, so that it's easy for you, so that you can like not stop. You can enjoy your life, your kids, your partner, sex, your everything, right? You can have it, because this is like, we spend our 20s and 30s, trying to get there. And now we're here. And so we get to like enjoy it. And I think that that's like the attitude everybody should have. I deserve it. I want to live like and feel great forever.
Yeah. I just want to circle back to Inner Balance. So vaginal insertion cream, all 3 hormones, progesterone, estrogen, and testosterone it's that.
Progesterone and estrogen, but progesterone converts to testosterone.
Got it.
So when you do labs, you'll see that your testosterone levels completely optimize as well, because it allows your body to have control over how much testosterone you make. And that's just based on genetics or but generally everybody lands in that really optimal range.
And women this is a daily dose that you're doing.
Daily, because it's bioidentical. So you're just simply replacing what you can no longer make.
Yeah.
So you have to supplement it every day.
Yeah. And there's a lot of benefit for vaginal estrogen. I mean, that I think
it's like doing an injection without an injection, right? Yeah. It goes like right into the bloodstream, right? We talked about that blood flow in that area.
Yeah.
There's a lot of blood flow in the pelvic region. And so we know that there's no liver, right? You can avoid the liver. You don't have to have, like when you swallow hormones, there's very low bioavailability. Like the liver destroys 80% of it. And so this way you avoid that and you don't have any liver metabolism. So you're taking advantage of a way to get, and you're going to get like a full systemic effect from it.
So what's the best way for people if they're interested and they want to learn more? They set up a consultation with you or your team?
We can set up a free consultation. We offer that. You can get started as well. There's a lot of information on our website, but we do offer free consultations. And they can get started right away too, if they even are hesitant, because sometimes the best way is to try it, and then you don't know how you're going to feel. And then you just dive in, and women know within 10 to 14 days. It's really that fast. Yeah. Especially with something like vaginal progesterone, they're going to notice right away.
I do just want to highlight, double click on that, because I think there's such a mindset that, at least for myself, and I think so many women are growing out of, evolving out of, healing from this very patriarchal version of medicine where we're placing this locus of authority outside of ourselves. And you and I were talking just before we started recording about the importance of course, lab windows, but really I've heard someone else say we don't treat the lab windows or the numbers, we treat the symptoms. And to underscore that for those of you watching and listening, that you do know best, you do know your body best, and every single one of us is different. We're not all going to be landing on the same number on that hormonal scale. And trust what you're feeling and try treating the symptoms and pulling that locus of authority inside and empowering yourself to advocate for what you're feeling.
You're absolutely right. And I tell women all the time, like, you know better than any lab test. I mean, even if they feel like they need it, I'm like, trust yourself, like, And, we can get labs, but they're going to be normal. They're going to be in a range, but you may feel better in a different range. Like, you need to be able to trust that. And I will always believe you over a lab test.
Yeah.
So,
and who's been taught that? I certainly wasn't taught that.
No.
Like, okay, doctor, what do you say? No. So I love that when I go to my functional medicine doctor, and that's what she said. She's like, I'm not so worried about the numbers. How do you feel? How's your sex drive? Okay. Yeah. Your sex drive is still kind of low. Let's boost your testosterone.
Yeah. Because if it's like, if your labs could be normal all day long, but you could still feel terrible.
Yeah.
I mean, it's not going to help you. Like,
right. And what is normal?
And what's normal anyway? And we already talked about how messed up the labs are. So it's just, you've really got to trust and then treat to the symptoms.
Yeah. It's a whole new way. It's really a new paradigm in medicine emerging.
It's the right way though. Women deserve to be in control of this. Like, they deserve to be in control, like, of their hormonal health. It's
of their life.
Absolutely. So there's no
hormonal health is the driver of the quality of our lives. Yes. I would say.
So she gets to say when she feels great.
Yeah. Yeah.
not the lab test.
Thank you so much, Dr. Sarah. I'm so grateful to have you here.
Me.
This has been amazing. And congratulations on all of your work and Inner Balance. And it's just, you're one of the pioneers leading this charge.
Thank you for having me.
Yeah.
I'm excited. I'm a fan
Yes.
of you.
Inner Balance, everyone. Check it out.
Thanks.